Welcome to Chettinad Academy of Research and Education Sleep Medicine course. I am Dr. Shiva. I'm Assistant Professor of Neurology in the same academy. I've been given the wonderful opportunity to talk on evaluation of neurological causes of sleep disorders, EEG and its management. In the next half an hour, we will go through what is an extensive topic, but in a brief way, regarding the various common neurological disorders which have implications of sleep and also its outcome, and the comorbidities, the evaluation, and the specific patterns. Let's go deep and dig in. Our objectives of this course are to explain how sleep disorders interact with Parkinson's disease, describe the bidirectional relationship between sleep and neurodegeneration, understand sleep epilepsy interaction and its management implications, identify common neurological and sleep issues in muscular disorders, summarize sleep issues in novel immune neurological disorders. The first disease which we'll be discussing is the Parkinson's disease. Parkinson's disease, as both Parkinson's disease and Parkinsonism are two different things. They are bradykinesia, rigidity, and 4 to 6 Hertz tremors are present. Of the Parkinsonism, the most common cause is Parkinson's disease. I am repeating the slide again. The syndrome of Parkinsonism comprises of bradykinesia, rigidity, and 4 to 6 Hertz rest tremor. The most common cause is Parkinson's disease. It is an asymmetric onset which has a slow progression and levodopa responsiveness. It is driven by alpha-synuclein mediated neurodegeneration, which initially starts in the olfactory regions and develops sets into the lower brainstem areas. Prevalence increases with age, 0.5%. It has a male predominance, and sometimes in rare conditions it is early onset, and often early onset are genetic Parkinsonisms. The key genes involved are LLRK2, GBA, SNCA, Parkin, PINK1, which are more being identified yearly. In various neurodegenerative disorders, including Parkinsonism, the prevalence of sleep disorders such as REM sleep disorder is very high. As you can see in synucleinopathies, which is Parkinson's disease, multisystem atrophy, dementia with Lewy body, the prevalence is close to 88 to 90%. In REM, the prevalence of RBD in neurodegenerative disorders other than synucleinopathies such as tauopathies is very less. In fact, in progressive supranuclear palsy and Alzheimer's disease, it is close to 5 to 10%. In corticobasal degeneration, it's only restricted to case reports. And frontotemporal dementia, palidopontonegral degeneration, it is virtually non-existent. In other degenerative disorders such as Godel-Pallinian Parkinsonism, it is close to 78%. In genetic disorders, neurodegenerative disorders which have Parkinsonism as a component, such as Huntington disease, it is only 8%. In spinocerebellar ataxia type 3, SCA3, it is close to 56%. Parkin mutation having genetic disorders are close to 10 to 50% based on studies. Main pathogenesis in Parkinsonism causing sleep-wake disturbances is the loss of non-nigral neurons which are responsible for sleep and arousal. These cause the RBD, which there is strong evidence for. They develop disease-related motor and behavioral features. Some of the pathogenesis of sleep-wake disturbances are due to medications for the motor symptoms, and sometimes it is combined. The motor symptoms itself can cause insomnia, excessive daytime sleepiness, and RBD. As we can see, the neuronal loss in arousal systems, mainly there is loss of noradrenergic neurons in the locus coeruleus, close to 50%. In the median raphe, serotonergic neurons are lost close to 30 to 40%. In ventral periaqueductal gray, dopaminergic neurons are also lost, 9%. The pedunculopontine nucleus, which has acetylcholinergic transmission, they are lost 50%. In basal forebrain also, cholinergic neurons are lost close to 30 to 40%. In lateral hypothalamus, hypocretin neurons are also lost, leading to 23 to 60%. However, in tuberomammillary nucleus, the histaminergic neurotransmitters are preserved. Okay. So, to summarize, neuronal loss in arousal nuclei such as locus coeruleus, raphe, pedunculopontine nucleus and hypocretin nucleus, they decrease the arousal drive and increase the sleep drive due to histaminergic imbalance, and it can cause excessive daytime sleepiness. Some of these things causes sleep attacks and also cause poor alertness, and some of these are due to dopaminergic medications also. To elaborate on excessive daytime sleepiness, excessive daytime sleepiness is more frequent in advanced PD, associated with a longer total sleep, not associated with sleep deprivation. It is associated with increased sleep drive. Sleep apnea, periodic limb movement disorder, fragmentation do not correlate strongly with excessive daytime sleepiness in Parkinson's disease. Dopaminergic drugs can trigger sleep attacks. A high dose of dopaminergic agonist may worsen EDS by blocking hypocretin neuron firing in the MSA disease. Marked hypocretin loss is also seen, which can lead to excessive daytime sleepiness, and some people show narcolepsy-like phenotype in MSA. REM sleep behavioral disorder is also seen in Parkinsonism. As I said, it is due to loss of non-dopaminergic lesions in REM atonia pathways. Substantia nigra is not involved. Key structures involved are subceruleus nucleus, locus coeruleus, perialpha region, ventral medulla, PPN nucleus. In MRI, there is a loss of neuromelanin signal in coeruleus nucleus. And insomnia as a cause in Parkinson's disease is generally due to depression and anxiety, and due to motor phenomenon which is not controlled, due to nocturnal akinesia, difficulty moving around the bed, dystonic cramps, pain, and including advanced disease itself can cause hallucinations, and there is a phase advance due to circadian rhythm abnormality and blunted melatonin rhythm. Medications such as selegiline, dopaminergic, and I am repeating the last line again. Medications like selegiline, dopaminergics, and impulse control disorders due to dopamine agonists also can cause insomnia. So, how do we go about and evaluating? There is a structured way to do it. First of all, we have to take a detailed sleep interview, essential for identifying the type and cause of sleep disturbance mainly. Standard sleep history has to be taken, such as the onset of sleep, bedtime, and also the total time in bed and number of awakenings. So, we have to even ask bed partner also, relating to clarify how these things are really true. Sometimes movements in the sleep the patient may not tell and the bed partner may tell. Timing and frequencies of arousals and awakening also we have to find out with the bed partner. Objective assessment is through a level 2 or level 1 polysomnography, mainly with video. Often need to evaluate RBD, periodic limb movements, sleep fragmentation, nocturnal motor symptoms, and obstructive sleep apnea. There are questionnaires and rating scales. While general sleep questionnaires help, but there are two PD related specific scales. The PDSS, called the Parkinson's disease sleep scale, objectively assess overall sleep disturbances and nocturnal symptoms in PD. SCOPA sleep score evaluates both nighttime sleep and daytime sleepiness, specifically in PD. Coming to the Parkinson's disease polysomnographic changes, mainly there is sleep fragmentation, and which causes increased awakenings, and it has frequent arousals, and this is mainly due to degenerative sleep-wake nuclei. RBD is also common in PD, which has dream enactment and violent movements, It is due to alpha-synuclein pathology in the brainstem. Excessive daytime sleepiness is frequent, and sleep attacks and sudden naps happen. It is due to dopaminergic therapy. Insomnia is common. It is difficulty maintaining sleep rather than initiation, motor symptoms, and medication side effects. Sleep latency is also prolonged with a delayed onset due to dopaminergic balance. Here we see a polysomnography of a patient with a REM sleep behavior disorder, wherein while sleeping he has roving eye movements, and then he has a burst of EEG muscle artifacts correlating to chin EMG and also to leg movements. You can see the anterior tibial and the right anterior tibial and the left anterior tibial are independently firing sometimes. The chin, there is lot of chin movement activities, and there is lot of roving eye movements also. There is one of the cause for sleep disturbances is nocturia. So how do we manage nocturia? Frequent nocturia with normal urine volumes can be due to sleep apnea syndrome. We have to screen for sleep apnea and treat accordingly. If the volumes are small and has poor urinary stream, probably it is prostatism, and we have to do a urological evaluation. Small urine volumes plus good urine stream may be related to Parkinson's, related to I'm repeating the line again. Small urine volumes plus good urinary stream can be due to Parkinson's related nocturia. This may respond well to intranasal desmopressin, rotigotin, oral amitriptyline, or if distressor instability is suspected, oxybutynin or tolterodin or miragabron also be helpful. General supportive measures apply to all. We have to decrease the evening fluid intake, empty bladder before bedtime, avoid evening doses of diuretics or antihypertensives, vasodilators, and also try to place a urinal at bedside. Management of difficulty initiating sleep in Parkinsonism. Difficulty initiating sleep early in the evening. If you are putting off lights off too early, it can lead to delayed bedtime. Okay. If difficulty initiating sleep early, evening with anxiety and behavioral issues, maybe it is due to anxiety and behavioral insomnia. One thing we can consider is to do counseling for underlying anxiety. We can treat with melatonin, zopiclone, doxepin. Sometimes if the difficulty initiating is due to restlessness, possibility of restless leg syndrome is to be considered. One can check the ferritin levels, correct the deficiencies, review and reduce the contributing antidepressants, consider polysomnography with leg EMG if diagnosis is uncertain. Pharmacologically, you can try gabapentin, pregabalin and tramadol. If the difficulty initiating sleep is late at night, it may be due to altered circadian rhythm. So, sleep hygiene optimization, reducing the evening dose of levodopa or dopamine agonist, and melatonin 1 to 2 hours before desired bedtime is ideal. If late night difficulty falling asleep with a mild hypomania is there, it may be due to an impulse control disorder. So, it is better to reduce or stop the dopamine agonists such as ropinirole or pramipexole and switch to levodopa monotherapy. Ensure close neuropsychological monitoring. Management of difficulty resuming sleep in Parkinsonism. Sometimes after sleeping, people may get up with an arousal and have difficulty in resuming sleep. In these situations, it is probably due to some amount of cramps or muscle pain or slowness due to bradykinesia, and then these are the candidates for who will be helped with rotigotin transdermal patches which have a good delivery of medications throughout the night, and an extended preparation of pramipexole or an apomorphine infusion or an intrajejunal levodopa carbidopa infusion. Or we can try to put on satin bed sheets to improve ease of movements rather than the furry bed sheets. If difficulty resuming sleep is with restlessness, again it can be due to RLS. We have to consider gabapentin, pregabalin. If difficulty resuming sleep is with anxiety, maybe adding night dose of mirtazapine, paroxetine or doxepin can help. If difficulty resuming sleep is with low mood, it can be due to a depressive disorder and treat underlying depression. Management of nightmares and agitation and Parkinsonism also will improve the quality of sleep and the overall quality of life. So, if a patient arises from confusion at night, it can be due to either hallucinations or psychosis or confusion. It is better to reduce the evening dose of dopamine or reduce the evening dose of antidepressants or assess for sleep apnea and consider quetiapine or clozapine. If a patient gets up with kicking, shouting and slapping like movements, it can be due to a REM sleep behavior disorder. It is better to ensure bed safety, remove hazards and such as any sharp objects or anything which can be picked up and thrown at people, and it is better to discontinue night antidepressants as possible because RBD can be worsened. And again evaluate for sleep coexistent sleep apnea, and melatonin and clonazepam can really help in these patients. In daytime sleepiness in Parkinsonism, people fall unexpectedly asleep and they can have sleep attacks. These can be due to sedating drugs, especially dopamine agonists, and warn patient not to drive, and we can decrease or discontinue the medications. I am repeating again. Daytime sleepiness in Parkinsonism is also an important issue. Patient can unexpectedly fall with sleep attacks, and one needs to review or discontinue sedating drugs, especially dopamine agonists, and warn patient not to drive. Sometimes they fall asleep more often than before. This is just daytime sleepiness. We have to consider the Epworth sleepiness scale and ask for hallucinations, do a PSG with MSLT and treat sleep apnea if present, and reduce or stop daytime dopamine agonists. Consider stimulants such as modafinil or methylphenidate. In Parkinsonism, some people have sleep apnea and stridor, and the incidence of PD is similar to obstructive sleep apnea. Just a second. I want to repeat the slide again. Sleep apnea and stridor in Parkinsonism is an important issue. However, in obstructive sleep apnea in PD, the prevalence of obstructive sleep apnea in PD is similar to general population, and if it is very significant, it has to be treated with CPAP. Stridor is especially a significant issue in multiple system atrophy, where it is also a synucleopathy. It can be associated with harsh, high-pitched inspiratory noise at night and dangerous. It can be seen in almost 40% of MSA, and it can be life-threatening if it is missed. And CPAP is strongly effective in avoiding stridor, and it improves survival. There are other methods also, like using auto CPAP or fixed CPAP, or if there is a coexistent central apnea, adaptive servo-ventilation also can be tried. Summarizing the EEG and sleep architecture abnormalities in Parkinsonism and other diseases related to Parkinsonism. In PD, the key EEG findings are reduced sleep spindles in non-REM sleep, alpha activity intruding into all sleep stages and may mimic wakefulness. And sleep architecture changes is false appearance of full night wakefulness, slow REM-like sequences may appear in non-REM. In dementia with Lewy bodies, wake alpha is slowed, such as the alpha rhythm instead of 8 to 10, it is slowed to 5 to 7.5. And non-REM frequency shift towards slow wave activity, and wake EEG may resemble N3 sleep sometimes. In PSP, similar to dementia with Lewy bodies, the alpha rhythm in the background is slowed, and marked shift of NREM towards slow waves. General PSG observations in all these disorders are occasional slow wave movements in non-REM sleep, which is a bit paradoxical, and REM features may appear in non-REM sleep. Sleep staging becomes challenging due to EEG intrusions. Since we have finished the Parkinsonism and sleep related issues, The next common issue we see in the clinic is the epilepsy, wherein these patients with epilepsy also have significant comorbid sleep disorders, and the medication due to epilepsy can also interact with the sleep, and the sleep itself can sometimes predispose to seizures, or sleep deprivation can conform to the. We have completed one disease. The next disease which is important is epilepsy. In epilepsy also, sleep has a very important relationship. Sleep can decrease the seizure threshold in some diseases. It can attenuate the seizure threshold. Sometimes sleep deprivation causes seizures. So there is an importance in studying the effects of drugs on sleep and also sleep on epilepsy, and it has implications in management. Epilepsy is a neurological disorder characterized by tendency to have recurrent unprovoked seizures. Seizures may be occurring spontaneously or may be triggered. Epilepsies arise from multiple etiological factors. They can be genetic, it can be structural due to, example, cortical malformations, stroke, trauma, any intracranial space occupying lesions. It can be metabolic, it can be infectious or unknown. Coming to epilepsy and sleep, as we are saying that in the NREM sleep, there is an increased epileptic activity. This causes mechanistically has cortical hyperexcitability, and it can facilitate intraictal discharges. In REM sleep, luckily, there is a decrease in duration. Here we can see the, I'm repeating again. Here we can see the effect of epilepsy and sleep. Overall, the sleep architectural changes are noticed in patients with epilepsy. Particularly in NREM sleep, there is a tendency to have increased epileptic activity with cortical hyperexcitability, and which facilitates intraictal discharges. In REM sleep, we notice that the overall density and duration of REM is decreased. This is mechanistically correlates with altered cortical inhibition, and this may be a cause for reduced seizure threshold. Sleep deprivation is a common trigger which can cause seizures. It is due to increased cortical excitability. Sleep efficiency also is reduced in epileptic patients. This may cause more awakenings. It can be due to comorbidities, or it can be due to medications also. And it is a clear notice that there are nocturnal clustering of seizures also, often during transition to NREM, and sometimes this is sleep stage dependent. Across sleep-wake states, the relative frequency of seizures compared to REM sleep are significantly noticed to be very high. Particularly in REM sleep, the lowest seizure frequency is seen with focal seizures, and seizures are extremely rare in REM sleep. In wakefulness, it is more common than REM sleep, high focal seizures. N1 sleep, it is the transition from wakefulness to N1 is the highest seizure recurrence or occurrence region, and in N2 sleep also it is 68 times more common than REM. In N3 sleep, it is 50% more common than N1 and N2. Coming to specific, I'm repeating the slide again. Coming to specific epilepsy syndromes which are associated with sleep, mainly in childhood, are the benign occipital epilepsy or the Panayotopoulos syndrome. The age of onset is generally 2 to 6 years. Seizure is characterized by prolonged eye deviation and autonomic symptoms, and maybe sometimes GI or cardiorespiratory also. Timing of the seizures is particularly in sleep, and vomiting is often seen, and it generally is a good prognosis seizure with remits within 2 years. In the EEG, the intracranial changes, occipital spikes are seen, and during the ictal changes, electrographic seizures arising from occipital region during sleep can be seen. Other important, another important, I'm repeating the slide again. Another important seizure or epilepsy syndrome in childhood is the benign Rolandic epilepsy, which is mainly an onset between 3 to 13 years. It is also called as benign epilepsy with centrotemporal spikes. And mainly it has partial seizures with paresthesias. It involves the lower face and it can associate drooling or dysarthria. Timing of seizures can be nocturnal mainly, many times 60% exclusively in sleep. It has cognitive associations such as naming problems, visual motor problems. This treatment is actually well tolerated and responds well to anti-seizure medications, and prognosis is universally better. Here you can clearly see that in the central regions, there are multiple spikes which are originating and then progressing to the bilateral hemispheres to electrographic seizures. This is benign. I'm repeating the slide again. EEG characteristics are predominantly centrotemporal spikes which are bilateral but independent, potentially during NREM sleep, and sleep architecture is of EEG is generally preserved, and you can clearly see that sometimes these can go into a generalization into either hemispheres. Electrical status epilepticus in slow wave sleep or ESS is an important condition where in sleep in young children, mainly of 4 to 5 years, near continuous spike wave discharges more than 85% of NREM epochs during sleep is seen. It can be absent during wake and REM also. Requires for diagnosis requires persistence Electrical status epilepticus in slow wave sleep or ESS is a very important condition where it is seen in children of 4 to 5 years of age, and it is associated with near continuous spike wave discharges in sleep, mainly in NREM, which is absent during wake and REM. It requires persistence across greater than 3 recordings in a month, and the seizures can be either partial or generalized, and sometimes atypical absence in awake state. This is associated with behavioral regression, cognitive decline, and speech also, sometimes in 50% of the people. This requires aggressive treatment with corticosteroids and IVIG or high-dose anti-seizure medications. Landau-Kleffner syndrome is a sister syndrome, which is also an acquired childhood disorder presenting between ages 3 to 8. It is characterized by epileptic aphasia with language regression, verbal auditory agnosia, epileptiform activity during sleep, and behavioral disturbances. Seizures are generally during sleep, but they are generally mild. Seizure types can be generalized or focal clonic or atypical absent seizures, but are less frequent and less severe. So the key similarities between Landau-Kleffner syndrome and ESS are both show a normal background while awake. Both may show rare focal or generalized spike wave discharges during wakefulness. Main differences are sleep discharges are generalized or near continuous in NREM in ESS. However, in Landau-Kleffner syndrome, sleep discharges occur mainly in the temporal regions and they are not generalized, mainly in the language areas. Acetylcholine receptor mutations can also be an important cause for epilepsy associated with sleep disorders, and the main identified one is the autosomal dominant nocturnal frontal lobe epilepsy, which is generally seen in age groups more than 20s and mainly in young adulthood, and the genes related to that are the CHRNA4 and the CHRN beta 2. This is currently the only epilepsy syndrome known to be caused by defect in neurotransmitter receptor that also regulates sleep. Seizures are stereotyped but within each individual, however, but vary between individuals. Mainly it is sometimes easy to pass this as parasomnia, but on close observation people will be having dyskinetic or dystonic movements. Mainly it can be sometimes complex behaviors, it can be sleep related violent behavior. 1/3 of the patients also experience NREM parasomnias. EEG findings can be ictal epileptiform activities over frontal regions, rhythmic ictal slow wave activity over anterior cortical areas. General problems in epilepsy are, as we said, it is fragmented sleep, sometimes in excessive daytime sleepiness. Contributing factors are primary sleep disorders or nocturnal seizures disturbing sleep or side effects of AEDs itself. And insomnia is reported close to 40 to 51%, and epilepsies with insomnia patients are known to have higher rates of depressive symptoms and poorer quality of life. It is very important to distinguish nocturnal epileptic seizures from movement disorders or psychogenic non-epileptic seizures, PENS, or parasomnias. The main clues are epileptiform activities are generally faster and rhythmic and which have a clear beginning and evolution and an end, unlike a periodic limb movements which can be waxing and waning. Psychogenic non-epileptic seizures rarely start during sleep. They even tend to be long, fluctuating, and often occur when a witness is present. Here is an exhaustive list of differences between nocturnal seizures and NREM parasomnia. As we can see, seizures can happen at any age group. Parasomnias mainly occur usually in childhood, and generally seizures stabilize over time, and in adulthood parasomnias disappear. Sleep stages, mainly seizures happen in NREM, and that too in the first two stages. Slow wave sleep in N3 stages, parasomnias generally occur. Timing of the night, any time of the night, seizures may occur, but however parasomnias occur in the first third of the night. Duration of seizures are generally 30 seconds to 2 minutes. Sometimes parasomnias extend up to more than minutes to 30 minutes. Event course, as we mentioned, they have a clear beginning, evolution, and end, and parasomnias have a waxing and waning pattern. Behaviors during nocturnal seizures can be stereotyped or dystonic. In parasomnia, it can be variable, complex, or may appear purposeful. End of event is abrupt in seizures, in nocturnal seizures mainly. They gradually return to consciousness in parasomnias. There are multiple episodes, more than 3 in the night in nocturnal seizures. However, in parasomnias, it is maybe 1 to 2. The EEG during the event in a seizure may show focal rhythmical activity, and muscle activity generally obscures everything. EEG, there is no focal rhythmic activity, and muscle artifacts will obscure everything. However, in the intrictal EEG, when we take in true seizures, the intricate discharges may be present, which is highly specific. So, sometimes EEG can be normal, and in parasomnias it is generally normal. The helpful clues is the careful history taking, as we already explained. The important features that increase the likelihood of nocturnal seizures more than parasomnias are short duration and more stereotyped events, clustering of events such as multiple events per night, prominent dystonic portion or tonic posturing, and frontal lobe epilepsy scale systematizes. I am speaking from the middle. The FLEP, the frontal lobe epilepsy and parasomnia scale, systematizes these historical features and is clinically useful. And mainly a video EEG will help in differentiating it by capturing the event. But sometimes muscle artifacts can also obscure these signals. Focal seizures may not be visible on standard PSG. Extended EEG montages increase the detection of focal nocturnal seizures and intractable discharges.